let's get rolling here. I think the time has come for us to have this conversation now that we're opening up. And until you make that personal decision that sheltering in place has ended, I'd like to share with you the reasons for the very best long-term solution I know. Now, a little about myself. I'm a physician. Specifically, I'm a pathologist, and pathology is all about the study of diseases. I have certification by the American College of Sports Medicine, and my interests lie at the intersection of the pathology of metabolic disease and the types of exercise that can treat it. Now, if you can set aside for a moment that this COVID-19 is a murderous virus, I'll share with you some things which are fascinating about it. Every virus has a target audience. And while age was a risk factor that might have taken the headlines earlier, as we acquire more data, we're learning more nuances that tell us that age as a risk factor is a little bit crude. And many folks in their 80s and 90s have gotten through a bout of coronavirus just fine. As many people are now aware, there's a common thread about who gets it. Principally, everybody gets it. COVID-19 is not very selective as far as who it infects, but there is a common thread about who gets it worse. People who have metabolic diseases, those people who have hypertension, diabetes, obesity, high lipid, blood lipids, these are all metabolic diseases and they share a common origin. So if you have one of these conditions, you already actually have the seeds of the others. And collectively, these are known as what is called metabolic syndrome. So I'd like to share with you what that means and what you can do with it. Now, COVID-19, when I talk to people, they aren't so much worried about getting it. They're more concerned about whether they can get through it. And for those of you who've been following this, you know that ventilators aren't the solution that we have been made to think that they might be, because among those who are put on a ventilator, there's a less than 50-50 chance of getting off that machine. In fact, recent data has shown it to be as low as only 1 in 10. So the vaccine, from what you might have heard, is more than a year away. The bad news is that no vaccine has ever reached testing phase for the other coronaviruses. So for SARS and MERS, we actually never had a vaccine. And the other bad part of the news is that vaccines typically work better on young people, and that it's very hard, or it's harder to get the vaccine to work on just the group that we want to especially protect. So the long and short of it is that you can't isolate forever. So hopefully tonight we'll answer these 3 questions. Why does COVID-19 take its fury out on those who have hypertension, high blood lipid levels, prediabetes or diabetes, or obesity? And I'll try to explain why these diseases of metabolism are the target for the virus. All these diseases, they tend to accumulate in the typical person who's sitting in the waiting room of an internal medicine doctor or a family practitioner doctor. And they might start with, for example, a lipid problem. And then a few years later, it's followed by hypertension. But these are the bread and butter of someone who has metabolic syndrome. So COVID-19 takes a particular shine to this group of people for reasons that I'll get to shortly. Um, so I didn't start and ask you whether you wanted the good news or the bad news first. So the layout of this conversation is I'll give you the bad news first, but I'll end with the good news. In fact, I think it's really good news because it's something that you actually have control over. So the first thing I'd like to address with you is why hypertension is a metabolic disease. We've been telling our patients that by taking medications for hypertension, we can reduce the blood pressure, and thereby we can reduce the stroke and heart attack risk. Now, this is a study that came out 5 years ago, and these these four groups here all actually have the same blood pressure. They all actually have controlled blood pressure. They all have a systolic blood pressure of less than 120. Now, how they achieved that was different. This group here achieved it with no medications. This one achieved it with one blood pressure medication. This two blood pressure medication. This one with three. And if you look at the risk of stroke on the left side, you'll see that the people with normal blood pressure who were taking three medications had nearly 2.5 times the stroke rate of people with no medications. And then it went up, not down, with each additional medication. So if it was truly that high blood pressure was simply high blood pressure, then lowering that blood pressure would lower the stroke risk. So why does the risk increase with each additional blood pressure medication? That tells us something about the metabolic cause of high blood pressure. Now, we've been telling something similar to our patients with blood sugar issues. We've been telling them that they should target and achieve good glucose levels. So I wish to play a game with you, and I think it will illustrate an aspect of metabolic disease by way of diabetes. So let's imagine tonight you have this dream, and it's actually a nightmare. You're playing Let's Make a Deal with the Devil, and so he has made you 20 again. That's great. But then he says, well, you're going to have to pick between type 1 and type 2 diabetes. So I'm going to pause for a second, and I want you to pick one. Which one would you rather not have, or the one you want would think has less complications? Okay, everyone ready? You got your answer in your head? Okay. So here's a study that looked at that. And for those of you who look at the second line, I'm going to make it a little bigger for you. Type 2 diabetes is more hazardous and lethal than type 1. So in other words, these two groups, they actually had the same glucose control level, but type 2 diabetics had many more complications. They had more heart attacks, they had more strokes, they had more kidney disease. They had all the long-term complications compared to the type 1 diabetes. So if glucose control mattered, it didn't affect the driving force behind this metabolic disease, type 2 diabetes. So the difference between type 1 and type 2 diabetes is actually not glucose control. It's something which we don't talk about very much. It's called insulin resistance. And insulin resistance for a type 2 diabetic is high, rises, and ends up much, much higher than a type 1 diabetic. Now, they end up in the same place with insulin production, but the type 2 diabetic has insulin resistance, and that's not affected by the diabetes medication. So the reason I bring this up is that if you don't treat the root cause of the disease, then it will progress over time. And in fact, that's what happens with diabetes. Now, I'm not focusing just on diabetes, but diabetes as an explanation for metabolic disease. So what I'm going to say, it can apply to blood pressure, it can apply to lipids, it can apply to diabetes, it can apply to weight. So this graph, I'm just going to talk about for glucose, but that's you can put in any of those four you like. So here's the timeline for the average Joe. And Joe started out, this is when he finished college, became an adult, and then he ends up in life on this side, the right side here. This is a timeline. So he might, excuse me a second. He might have never recovered from freshman 15, put on some weight, and then he was focusing on his career, maybe never started or never did regular exercise, and maybe he's been hunkering down and now has COVID-19, or at least the COVID-19 that comes from sheltering in place. So he's added now 19 pounds to that 15 pounds. So they're somewhere now in the middle. And maybe the glucose level is normal, maybe it's slightly rising. But there's somewhere in this middle zone here called metabolic syndrome. And he's in good company. There's approximately 85 million people in this country who have metabolic syndrome. And let me share with you the type of people who are more likely to get metabolic syndrome. It's more common in men. It's more common in those who are overweight. It's more common in African Americans, and it's more common in Hispanics. So if you think back, that's the same group that's at risk for COVID-19 complications. So at this point, his glucose has been going up, but not enough to be diagnosed with prediabetes. So here's the cutoff here, this red line for prediabetes. The people who are on metabolic syndrome are on both sides of this line here. Now, I'm going to add in something that you don't normally see, which is insulin level. Now, insulin is made by the pancreas. So from the time period that the glucose is normal, the insulin level has been rising. And this is a typical course of someone who has metabolic syndrome, prediabetes, diabetes. So the pancreas has been trying very hard to increase its insulin level. In fact, that is the exact reason why glucose levels haven't been rising. It's because this rising insulin has been tamping down this average glucose level. But you notice at this point, the insulin level starts going down. And the reason it's going down is that the beta cells in the pancreas are dying. They're literally dying from being overworked. So the insulin level starts going down, and that's when you begin to see the rise in glucose. This is way before it even crosses the threshold to become diabetes. So that's why during this time, lipid levels are going up. That's why blood pressure has been going up. Because when we reach this point, there's something else that we don't normally measure, and that is insulin resistance. So insulin resistance is something, our cells in our body, that you can actually measure from and calculate from glucose and insulin levels. This insulin resistance goes up progressively in type 2 diabetes and metabolic syndrome. So if you look at this line, this is time going in this direction, and then insulin resistance going this way. You notice that it looks like aging. In other words, it's getting worse and worse with time. But what I want to share with you is that the same thing that's happening that makes us susceptible to COVID-19 is going up parallel, like the opposite track of a railroad, that's rising with age. And so it seems like it's age related when it's really not age related. So we'll come back to that in a moment. So we're just change gears and we're going to talk a little about philosophy. And this is the philosophy that's misleading us. We have conceptualized disease and said, we'll measure this with a test. So if we have high blood pressure, we measure it with blood pressure cuff. If we have diabetes, prediabetes, we measure it with blood sugar. And the idea is that we want to, by controlling these, we have our good outcomes. So we have drugs which are targeting these lab test results. So the theory being that if you take high blood pressure medication and it makes your blood pressure lower, or it makes your glucose lower, then it should have more of these desired outcomes. But clearly that's not the case. We know that diabetes actually worsens with each additional diabetic medication that is added to the regimen. If it was an effective drug, then we wouldn't have these complications that occur with the progression of the disease. And the reason is this, at least one I'd like to offer you, is that there's other driving forces behind these metabolic diseases. And we mentioned insulin resistance. I'm not going to talk about all these other ones, but these are factors which are well recognized as driving forces behind the metabolic diseases, which are not addressed by the drugs. So the result is we do not have a complete effect on the underlying causes of these drugs when we treat them solely with medication. So in other words, correcting blood pressure, lipids, blood sugar with exercise treats the underlying disorder. And this remedy is superior to the medications. COVID-19 doesn't ask you whether you are a drug well-controlled person with high blood pressure. COVID-19 doesn't ask you if you are a drug well-controlled person with sugar problems. It attacks the underlying cause of the metabolic disease that our drugs don't address. So let's come back to something that you may be more familiar with. This came out of the New York Times recently, and this graph shows us that among the people who did very poorly with COVID-19, this tiny sliver, they had no known comorbidities. In other words, they did not have those diseases that we're talking about. Typically, the people who were at great risk had 1, 2, or 3 of these illnesses we're talking about. What are these illnesses we're talking about? Hopefully you're familiar with this. This data is from the CDC you're looking at, and these 10 conditions account for over 90% of hospitalized patients. I like this graph because it breaks it down by age. If you look at the olive color here, among those who are 50 or less, less than 50, you can see obesity accounts for nearly 60% of those young adults who are hospitalized with COVID-19. Now, what about those other diseases that are not showing on the graph? There's dementia, there's cancer, there's strokes, kidney failure, and atrial fibrillation. Now, you may also ask, well, I know some young people who don't have any of these. What's causing those? Now, I'll just throw a couple extra in there because they don't necessarily come right to mind, but they're fairly common. And that is those who vape. Those electronic cigarettes have substances which damage the lung. And those who smoke marijuana, that's also damaging the lung. And we know that because of the data that initially came out of China. When we talk about Wuhan, I don't know how many of you know, is regarded in China as the Detroit of China. It's the major manufacturing center. And Wuhan's air pollution is 80. What does 80 mean? Well, the World Health Organization highest tier for most polluted is 35. So it's more than twice the highest cutoff. So the people who live under these conditions suffer from lung damage. In addition to, uh, like the people we have in our country who vape, they also have a very high level of smoking. And all this leads to hypertension. How do we know that? Tragically, children in China begin to have abnormal blood pressures in areas that have high air pollution rates. So that's trying to pull together this puzzle. You came here and because you want to hear why people have trouble with COVID-19. So here's the missing word in our crossword puzzle, and it's ACE2. ACE2 is a naturally occurring enzyme found in the blood and on the surfaces of cells. It goes up with insulin resistance. It's kind of like a measurement of bad health. So ACE2 is our body's way of protecting ourselves from the complications of all these things you see on there. It's higher in hypertension, it's higher in diabetes, it's higher in obesity, it's higher in lung disease. All of these causes rises in ACE2 levels. ACE2 often also happens to occur in high levels. In fact, the highest level is in the lung. And so I think you're beginning to see the picture that ACE2 plays, because ACE2 actually is that thing which is going up with time, with sedentary behavior and from hypertension and diabetes and all these metabolic diseases. Now, what else likes ACE2? Well, COVID-19 likes ACE2. So the more ACE2 you have in your lung, the more ACE2 you have in your heart, in your blood vessels, in your kidneys, in your gut, the more severe reaction you'll have. So it's the virus sees this as a target-rich environment. So conversely, if you have fewer ACE2, you're likely to have a much less severe reaction to a viral infection. So here's where we get into the happy part of the talk. Long before there was COVID-19, there was a lot of research on ACE2. And it was found that among people who have chronic heart failure, that aerobic exercises normalize the number of ACE2 receptors in the heart. In fact, a single episode, a single session of aerobic exercise can improve ACE2 levels. And not surprisingly, the higher the intensity of the exercise, the greater reduction in ACE2 levels. Finally, everybody's worried about lung disease and COVID-19. And this was an experiment done with rats in which they gave them a very noxious agent to their lungs, which causes lung scarring. And they took some rats and they exercised them and they let the rest sit in their lazy boy recliners. And what they found was that exercise not only normalized the level of ACE2, but it reduced the lung scarring. So it's a pretty convincing protective effect between exercise, ACE2, and the side effects, or the complications that we're seeing with COVID-19. Now, supposing you're in the group that wants to wait it out, you want to shelter in place. So I have a couple thoughts to share on that. You ever wonder why they call it COVID-19? Well, here is the Spanish flu of 1918. But here you can see the Spanish flu of 1918 wasn't confined to 1918. In fact, there were three major peaks. The first one actually was not that serious. It was the second one that was more lethal than the first one. And there was a period of time between the first and the second one. Now, if you've been following the news, you probably know that they're expecting this um, infection to drop off during the summertime because heat is not too friendly to the virus. But they're expecting a resurgence of disease come the fall and winter. So I want you to start thinking about what you're going to do come Thanksgiving or Christmas. What about COVID-19? Are you going to see COVID-20? Are we going to see COVID-21? So I would suggest to you that this period between this peak and this peak might be a good time to do something that will improve your chances. So you say, well, I've had this my entire life. I can't change overnight. Well, people overestimate what they can accomplish in the short term, and they underestimate what they can accomplish in the long term. The rule of compound interest also applies to exercise. Your goal realistically isn't to make yourself COVID-19 resistant. Your goal, if you're in the group or the rung that's destined to be on the ventilator, is to get yourself to the hospitalized group. If your goal is, if you're in the hospitalized group, then I would suggest to you that you want to use this time period to get yourself to the rough week at home group. And if you're in the rough group at home group, then maybe your goal should be to get yourself to the mild cold group. And although this is kind of lofty, it's maybe worth going for. If you're in the mild cold group, then get yourself to the no symptoms group. Fewer ACE receptors, fewer symptoms. So for too long, we doctors have been telling our patients that no health problems is the same as being fit. And I'm here to say that being fit is not the same as having no health problems. Not taking medication doesn't mean does not equate to being healthy. And I hear people say, I'm thin, and I say that doesn't make you healthy. Some people, they might do walking, and those people, they have no strength, because what happens with time is a process called sarcopenia, in which you gradually lose a type of muscle fiber that's associated with strength. And these are also related to COVID-19 susceptibility. So being fit means that you are able to maintain and perform at a level that you were used to being able to perform at. The true goal of exercise is to set a performance bar that your body can aspire to. So if you lack stamina, you want to do an exercise that makes your body reach for more stamina. The same is true if you don't have a great deal of strength. You want your body to reach for more strength. This is adaptation that you're trying to affect. Same with flexibility. And I want to also make a plug for body composition. We were talking about tests that measure something that's not quite right. Some people use the bathroom scale as their benchmark and their way of improving. Now that's easy to do, you just step on the scale. But really what you want to do is change your body composition so that if you have more fat, what you want is to exchange that for more muscle. They're the yin and yang of body composition. It's not weight that matters as much as body composition, or as exercise physiologists like to say, lean body mass. So I'm going to spend a few minutes and let's talk about the goals in exercise. This is the American College of Sports Medicine. It's also the U.S. Health and Human Services goals. 150 to 300 minutes a week of walking, cycling, or jogging. This is half of what we're talking about. Aerobic exercise. The principal fuel that's used in aerobic exercise is fat. It is a light resistance load which has many repetitions. So if you think about swinging one foot in front of another or putting the pedal round and round, that is a light load that's many times repetitive. So that trains the type of muscle fiber that's associated with stamina. There's the other half, and most people who do some form of exercise don't do this, but this is part and parcel of the American College of Sports Medicine and the U.S. Health and Health Service recommendation. Twice a week, large muscle group, progressive strength training. Why is that? It's because the metabolic fuel that's used in this is glucose. Let's just pause for a moment. What's the principal problem in metabolic diseases? Typically, it's glucose. That's why we have so many people with prediabetes. So it's a heavier load, fewer repetitions, and the goal is to make the body adapt and produce more strength fibers. So together, aerobic and resistance exercise is a complete way of achieving that. So I want to address this because I get asked this all the time. I walk, I jog, is that enough? Now I'm going to pick on myself. I'm a cyclist. If I were to ask this gentleman who I met in Colombia, and you can notice that he has a special bike, he's turning the cranks with his arms. So he's getting aerobic exercise of his upper arms, right? As opposed to someone who walks or cycles. They have aerobic exercise of their leg muscles. So whether you talk to this gentleman or the people in the previous frame, they're exercising half their body, half their muscle fibers. So in essence, they're exercising half their body mass. So it is not enough. So this is the page I was promising you at the end, next to the end. Darwin, or more accurately his followers, said, survival of the fittest. This virus adapted to our changing population. 200 years ago, if COVID-19 had come through our present world population, it would not wreak the havoc it does now. This virus has adapted to us. For us to survive, we have to adapt to this virus. So I hope this has been a message of hope, and that you possess, and I want to leave with you in your possession a way of improving your chances. There's no magic pill. I wish I could give you a magic pill. It's hard work. This top link is a link to a chapter from my book. This chapter you can download. It's a home gym routine that you can do. Of course, you're welcome to get the entire book from Amazon. This second link is the exercise workout that allows you to keep track so that you have accountability for what you're doing. This bottom link is where I'll post the video link in case you want to share this recording with your friends. And that's last one is my email, of course, and you can welcome to get a hold of me afterwards. You would say, what's in the chapter? I'll show you what's in this chapter. So my neighbor is a fitness instructor, and we got together and we came up with a whole body exercise program for every single level. So this is an example of chest presses, and these are 2 pages out of it. So you can see if you are here, you can do wall push-ups, or if you're want a more challenge, you can do chair push-ups, or if that's too easy, you can move to knee push-ups. And then there are other types of push-ups which are even harder, but there's something for everyone here. Now, I've given you all some motivation and a reason to use that time before the next COVID wave. But it's up to you to take that motivation and make it a habit. And that's actually the hardest part about regular exercise. It's regular. So you know who you are. Some of you need to find a friend and make a pact. They're going to work out together. Some people can do it on their own. And some people, well, money's well spent if you find an online trainer. So we will stop things here, and